We all know that housing is more than just shelter. We've been hearing that theme over and over again. It's also a foundation for so many other things. A good start in life, a strong education, access to jobs, and other opportunities as well. A growing body of evidence, much of which has been laid out today, also demonstrates the strong linkage between housing and good health and the role that homes can play as a platform for the delivery of health care and other supportive services. In fact, in part, Ron Terwilliger, in speaking to Secretary Carson, began to engage in that point. Exploring these connections will be the subject of our next and final panel of distinguished guests. Moderating this panel of experts will be Dr. Kamillah Wood of Stewards of Affordable Housing for the Future. Dr. Wood, distinguished panelists.
All right, am I on? Oh, cool. So I know we're the last panel of the day, so I know everybody's extra energized. And if you ever have heard me talk before, I always encourage people to get up and walk around. We don't take offense to that because sitting is the new smoking. So please take a break and enjoy this conversation. We're really hoping that this will be an invigorating conversation to close out the day. Again, my name is Dr. Kamillah Wood. I am Senior Vice President of Health and Housing at Stewards of Affordable Housing for the Future, or SAHF. I am also a practicing pediatrician, and so I carry multiple hats in this work, and really excited to shape a conversation that I think is a little bit different in the health and housing discussion. So I have one slide, hopefully. Uh-oh. It's not coming up? Green button with the arrow. Yep, I'm pushing it. Well, we'll wait. I don't need this slide. Oh, there it is. Awesome, very good. So I really love the conversation today because I would argue everything we've talked about up until this point has been about health. Let's be clear, having safe, healthy, affordable housing is a health issue. So before you get to the services, before we get to other elements, that is such a critical piece about being healthy. And so really what we wanted to do in this conversation is really frame a public health discussion about the intersectionality between health and housing. So this is a slide that I use often from the Bay Area Regional Health and Equities Initiatives that looks at a kind of spectrum of where we can have interventions along the kind of health systems framework. And a lot of the traditional work has happened in this kind of downstream part of the slide, which is towards the right here, where we focus a lot on communicable diseases, chronic diseases, and services, which is really, really important. But we know when you intervene on health care alone that impacts your outcomes by 10 to 20%. We've talked about the social determinants of health a little bit today. And so really the thought is, how can you have a broader impact on the populations that we're serving and focus on population health, which really requires us to move upstream. And that's where housing plays such a tremendous role, particularly in the community development conversation, and housing really being an anchor to the interventions that we can do. So as you can see towards the middle of this slide, we have living conditions that clearly housing is a big part of that, but we've also talked about transportation today, we've talked about education. All of that is really critical in informing policymakers about how we can have these broader interventions and impact on vulnerable populations. In addition, I wanted to point out the importance of moving way upstream and looking at and addressing social and institutional inequities. It would behoove me to also bring up health equity as a big part of this work and call it out deliberately. Oftentimes we want to be clear about who we're serving and what we're trying to accomplish. And so really in this conversation that we hope to have today is really thinking about housing as an anchor in community development, place-based work, and really improving the health of not just the individual, but communities and neighborhoods. So I'm pleased to have such a distinguished guest with me today who are also experts in the field. And I'm going to have them introduce themselves as well as tell you a little bit about the work that they're doing in this space and also address this question. Why are housing investments important in the context of improving the health of communities? So we'll start with my good friend, Dr. Doug Judy, another pediatrician. We have three in the room, and Megan Shandell, if I don't give her a shout out, I want to make sure that there's a doctor contingent here, so that's important.
And we're all pediatricians too, which is funny. Yeah, my name is Doug Judy. I'm a public health professor at UC Berkeley as well in the School of Public Health and executive director of the Build Healthy Places Network. We're a national nonprofit. We're based in San Francisco, and we work across the country to catalyze and support community development and health working together. Because we really believe by joining forces, these fields can have a more profound and a more impact on the health and well-being of low-income neighborhoods and the community and the folks who live there. I'd say that really what we make the argument that there's a health return on investment, a health ROI to the kind of community investing, the infrastructure, the housing that all of you here are working on, and that we don't measure that adequately, we don't acknowledge it fully, and we certainly don't get paid for it by those systems and institutions and organizations that benefit from having healthy, productive residents. So our work really has early on focused mostly on the community development sector. The affordable housing folks and the Federal Reserve System really helped make that health link. We've also worked really closely with the public health sector to, they often don't know anything about community development or affordable housing or finance, so we work a lot with them to make those connections. And now we're increasingly working with the healthcare sector. What's the opportunity there, and we'll hear some of that today, to bridge that gap and use some of our healthcare funding differently. So in terms of your question, Kamillah, for me, the role, and you've alluded to it, for housing is the idea of toxic stress. Some of you may have heard the term toxic stress before. It really is it's the lack of control. It's not knowing how your week is going to end, how next week's going to go. Are you going to have money for your car payment, for your apartment, for your kids' tuition in their their public or their elementary school or their preschool, and that really gets embedded in your body and has long-term consequences. One of the most profound stories that I've heard was a guy named Sheldon Cohen at Carnegie Mellon in Pittsburgh, and he did a study looking at college students, and he actually put cold viruses directly in their nose to determine who got sick and who didn't. What he found was those whose parents owned their home when they were children compared to those who didn't own their home when they're children. Those who didn't own their homes were much more likely to actually get sick. So there was a long-standing impact from the relative instability that came from lack of home ownership. And that was just a proxy for poverty, basically. So this idea of biological embedding, I think, and the insecurity that comes from unstable housing is the big driver for me.
Okay, David?
So hello everybody. I'm David Fukuzawa. I'm the Managing Director for Health and Human Services at the Kresge Foundation, a national foundation expanding opportunity in America's cities. And you might, I think my boss was here yesterday earlier to open the conference. You might have heard a little bit about the foundation. We actually have 6 program areas, of which I direct the Health and Human Services. And so one question might be, how did we come to housing as really a critical priority for us? And I just want to say, sort of in passing, that even though we have 6 program areas, housing is not one of them. And Fred Karnas, I know, is in the room. Many of you probably know him from his days at HUD. But Fred, when he first came on board as a fellow at Kresge, did a study of housing investments. So even though we didn't have a housing program at Kresge, over 5 or 6 years, Fred, he had found that we had invested $100 million in housing-related projects. So we're not a housing foundation, right? But one of the things we found very early in the health program was that health was probably not only a social determinant of health, we've come to believe it is probably the most critical social determinant of health. What is lost in the current health care debate, is that the real problem facing the country, and I think the doctors here would agree, is not infectious disease, it's really non-communicable disease. Mm-hmm. Because this is kind of a tidal wave, which is going to hit us because of age and disability over many years, things like obesity and diabetes. People who are paying attention to this know that this is kind of the coming wave. And so people, obviously, with those issues at the top of mind, were thinking about eating and physical activity. But let me give you just a short detective story about how we came to housing, because we were kind of in with that crowd, also thinking about the upstream determinants, thinking about healthy environments and things like that. But we began looking very early at the issue of lead poisoning because we actually had an opportunity to restart the grant-making program at Kresge about 10 years ago when RIP came. And we wanted to find an easy win. And nobody was really nationally paying much attention to lead poisoning. People thought we solved that problem, right? Well, it's still actually a pretty significant problem, dropping over a number of years, but it's still pretty serious, and very serious still here in the city of Detroit. As we began to take a look at that issue, which is basically houses poisoning children, there was more than the issue of lead. There were issues of allergens in the household, asthmagens in the household, so asthma became another big issue. Safety, another big issue. So the issue around how houses themselves can make you well or sick. You know, and this led us into the whole realm of substandard housing, and the fact that, you know, if you are of low income in this nation, you're very likely going to be living in subsidized housing or substandard housing. And those houses tend to have these kinds of risks to health. But as we began to look at why people were living, so we kept moving upstream on this issue in substandard housing, we realized it was also a neighborhood issue. So they were living in neighborhoods that had a lot of things that were lacking. They were lacking grocery stores, they were lacking safe streets, they were lacking banking, they were lacking access to lots of amenities and goods that we all come to expect in a healthy neighborhood. So there was issue around that, and it was really then related, we saw that the issue of availability and affordability were also impinging on the fact, on this larger health issue. The other thing that we were beginning to track is in the healthcare world, you know, the highest cost patients, or the majority of the costs in the system are actually driven by a small number of patients. They tend to be, as you would expect, older and sicker people, but often at the root of that is housing insecurity, instability, and/or homelessness. And in many cases, you know, people who are being admitted and readmitted into emergency rooms had no place to go. So they were just bound to come back to the hospital. But now that hospitals, you know, there's a penalty for readmissions, now there was an issue like, well, we have to get ahead of this issue, and the issue is housing. You know, the housing is medicine in that sense of really, in order to control the cost, we're going to have to get ahead of this and find housing. And then you run into the issue of like, well, where is that housing going to be? And it can't be just any housing, it needs to be supportive housing. So as we began to scan, you know, the issue of housing, everywhere we looked in terms of how we were going to get ahead of, you know, the issues of chronic disease, housing kept coming up as a sentinel issue. And it was one that was clearly beyond the capacity of healthcare alone to deal with, or much less public health. So that sent us on a quest to really find this nexus between the housing and health worlds, which is, I think, why we're here. So.
If I can add actually one thing just quickly. I think just to make a particular point, you know, pediatricians historically didn't think children coming from low-income neighborhoods tended to be sicker and tended to not do as well in school, and there was a feeling that was part of what led them to be in those poor neighborhoods. It was the families themselves until we came to understand lead poisoning. And then we started screening for it. We as doctors don't go out and take that lead out of the houses. We don't have to solve the problem. We need to identify the problem, have the political clout to demand that there be resources for those families, and we refer them and we follow them up very carefully. And now that we understand a lot of the social environment is affecting biology in a similar way, there's a growing sense among the physicians that that is in fact part of our responsibility, much the way lead went from being sort of a social issue to being one of actually being poisoned. The kids are being poisoned now by the inequities that we were talking about.
And that's a great example of kind of a healthcare system kind of being the screener and understanding the context, and then being able to add some level of discussion to the intervention or how we should move forward. And Bon Secours Hospital System has done this very practically and executed it on the ground, and so excited to hear from you, George.
Sure, thanks, Kamillah. I'm George Kleb. I'm with Bon Secours in Baltimore, Maryland. I do housing and community development work for the system, but in Baltimore, we're a community hospital. We have, you know, acute and emergency care, but we also have a full spectrum of behavioral health, you know, including mental health and addictions treatment services. But we also have community support services through a subsidiary of ours called Community Works, and that runs the gamut from early childhood development to workforce development with a particular focus on training and placement for people returning from incarceration. It also includes youth services. It also includes financial literacy and other kind of support services. And then finally, we also develop, own, and manage affordable housing. So over the last 25 years or so, we've assembled a portfolio of about 800 units, both renovation and new construction for families, individuals, and persons with disabilities. You know, the key, I think, for us is very similar to what you've heard already. Another way to put it would be stability. When you're trying, we're very much a community-based institution, and we're trying to provide medical care, which is now, of course, increasingly outside the walls of the hospital and dependent on success outside of, you know, in many ways, if someone makes it to the emergency room, we're already in cleanup defeat mode because it's that the disease or what other situation has gone too far, which is not the model we had back in the 20th century. But it's trying to provide stability, really at the basic sociological level, kind of like the Maslow food, shelter, and safety level, which of course creates lack thereof creates toxic inflammation. Our institution in particular has put a big emphasis on trauma-informed care, and when we look at what's causing the trauma, it essentially goes back to what other folks on the panel said. It's housing instability, it's neighborhood upheaval, it's, you know, lack of knowing what's going to happen tomorrow.
So, George, I think the work that you all are doing is incredibly fascinating, particularly being a health and hospital system. But the work that you do is very strategic in regards to where you are, very place-based. So I didn't know if you could just talk a little bit more about the strategy, about where you actually develop your housing, and then we can have Doug maybe give some other examples of where there's been some place-based initiatives around housing and community development that are really lending itself to improving the health of the communities.
Okay. Sure, and as I said earlier, you know, we're in West Baltimore. Our primary service area is just around 158,000 people, sort of central West Baltimore and Southwest Baltimore. Initially, when we started investing in housing and really moving outside of, going to the point where we were going to be drivers of housing investment, we focused on the blocks around our hospital. Actually, it goes back to the last major tax reform in, you know, the 1980s when the tax laws changed, and we saw, and a lot of towns did, wholesale abandonment of rental properties with, you know, absentee owners and stuff. So it went to the point where 2/3 of the houses surrounding Secours Hospital were vacant, just in the immediate blocks. And in particular, a 3-block area leading up to the hospital from downtown, out of 101 residential units, we went from 20 vacancies to 67 in about 3 or 4 years. That combined with what at the time was a spike in open-air drug dealing around the crack epidemic put us in a position where providing acute health care under the old model, which is all based on volumes and acuity, was challenged. We invested in, at the time, we were investing in the physical plan of the hospital. So we put, the last major investment was an addition to the hospital, which at the time was about $30 million, which, you know, in 1993, that was a lot of money. And we put new operating suites together, new imaging, new ambulatory care, but the business model was based on volumes, and volumes actually went down. When we dug into, like, why are the volumes down are down because of the conditions in the neighborhood, even though the emergency room volumes continued at the same level. And even as length of stay and that's played out even over the last 20 years, even as length of stay goes down, and even as number of admissions goes down, the number of beds in the hospital goes down, the emergency room visits remain constant. And that's where, you know, the really need to try to affect the stability in the outside environment becomes really important.
And Doug, I didn't know if you could share some other examples in your work, especially in kind of being this bridge where people come and look for examples where this is done well. If you could share some other examples of some place-based interventions around community health.
Yeah, the one that comes to mind actually has been mentioned on stage twice already today. Renee Glover and Ben Carson both mentioned, without saying specifically, the East Lake neighborhood of Atlanta, and that's purpose-built communities that many of you are probably familiar with. I was just there last week because the American Public Health Association conference was in Atlanta, and we took a tour of the neighborhood so that the public health folks could see what 20 years of community investment could look like. And you know, a few things that really, I think, come from that. One is that their approach is not just housing, it's really holistic. And so they're looking at education, they're looking at housing, and they're looking at community health and well-being as they describe it, which is really around, again, to be very broad about health, it's around having access to grocery stores and bank branches and public places to play for the kids and to be outside for the adults. And it's very geographically focused, which I personally think is an important component because you then focus on every single individual in that neighborhood. And one of the things, we stopped by the elementary school as we were walking across the campus, and a bunch of kindergartners were playing outside, and Carol Naughton, who's the president, mentioned to the group, or asked the group, what do you see here? And three things came up. One was that they were very mixed race. So there are increasingly white families who want their kids to go to the school there because the school is so good. Second was the kids were all paying attention and playing and following the rules, so they had good self-control, which is really a very good sign of a more stable upbringing. And the third someone pointed out was that all the kids were, none were obese. Now this is a population of mostly low-income African Americans, and nationally, you'd expect almost 50% of the kids to be overweight. They have never done an anti-obesity intervention there in any meaningful way. It came from having the families being in stable environments and feeling comfortable making the choices they really want to make. And that's where I think there's real potential here, that rather than us spending a lot of money on the bariatric surgery for the morbidly obese or you know, all the extra, the obesity clinics, that investing more up front to make sure these families grow up and the kids are stable from the beginning is really where we're going to get the real bang for the buck, I think.
Yeah, yes, go ahead.
Can I add something on the East Lake story? Because I've actually been to East Lake several times, and many of you may even know the origin, but it happened. I mean, it was a dangerous public housing site, and there was, I think it was a foundation, I can't remember the name, wanted to understand like where the crime at that time in Atlanta was coming from, and they discovered it was really like one zip code, and the felons were actually coming from one community, and it was East Lake, and they said, well, we have to concentrate resources there, and so you flash forward, you think, well, the solution there was not really, in the end, was not a law enforcement solution. Right. It was really a housing and habitability and quality of life solution in many ways. Yeah. But I want to respond to George, because George, you may think that George's Bon Secours is an anomaly, but increasingly, people look to Bon Secours certainly as a leader, but there's now many, many other hospitals that are really thinking about housing as an intervention beyond the clinic. I was talking with the CFO at University Hospitals in Cleveland, and they had done an analysis of lead poisoning, and most of the kids were actually coming from one single community nearby, and they also overlaid the crime data. And as you can imagine, there was a pretty close match between where the crime, where the highest crime rates were in that neighborhood and the lead poisoning. And so at that point, they realized that they had to commit to improving the housing in that neighborhood. And I can give you other examples, but hospitals are increasingly realizing that that housing may be the most critical investment they make to get to some of these upstream issues. In fact, we're supporting a relatively new organization called the Center for Community Investment, and one of the things that they have done is build a cohort of hospital executives around how can you invest in your communities to make them healthier, and the one issue that they want to focus on is housing.
Yeah, absolutely. So we're getting to a point where we will begin to take questions, but I had one more question specifically for you, David, in kind of doing this work. And one of the issues in this kind of complex ecosystem of improving the health of communities is who's at the table from a stakeholder perspective and who's engaged in actually creating the solutions. So I was curious, to start with you and then hear from others, are there non-traditional stakeholders that should be more engaged in this conversation that aren't there? Or who should we be trying to pull into this conversation? Particularly, as you mentioned, you're not in the necessarily housing business, but obviously understand it being such an integral role. So who else should we be thinking about in that regard?
Well, you know, you could actually answer that question, Kamillah, since we provided you guys a grant.
It's a good plug.
So there's, obviously, we you know, the affordable housing community, but I also think that the private developers need to be part of that conversation. Public housing needs to be part of the conversation. I think increasingly we're seeing, besides hospitals, managed care organizations also needing to be, and I think, you know, Medicaid directors, things like that. There's a big conversation to be had, and I think, as you know, what's clear right now is we're only at the beginning, because these are, you know, two worlds which speak radically different languages. I came in the middle of the housing finance discussion, which, of course, left me totally befuddled. But I assure you that I could bring you to a healthcare policy discussion or a clinical discussion, which will leave you equally befuddled. And bringing those two worlds together is actually a challenge, you know. So.
Absolutely. And Doug, your organization has actually tried to mitigate some of those challenges when you begin to engage across sectors. So didn't know if you want to speak to that as well.
Yeah, so part of what we've been doing the last few years is actually identifying, as David was saying, there are more and more examples of Bon Secours, and we're about to start a project with the Catholic Health Association to really try to summarize across the healthcare systems, what are the different activities? Dignity Health, for example, has a $120 million community economic investment fund where they provide low-interest loans for all types of affordable housing, but other forms of community infrastructure. And it represents about 2% of their treasury. So if Dignity Health can do that, other hospitals could start to do that, you know, and $100 million here, $100 million there, and it starts to add up over time, right? And you know, we have a jargon buster on our site. We have to describe, you know, you talk about the CDC versus CDCs, and people, I've had people go to an entire housing conference and realize that we weren't talking about a place in Atlanta. Like, it just occurs to them at the very end of the day, like, wow, you just heard a very different day here today. You know, and we have a series of essays, we call it Crosswalk. It's a series of essays that actually describe some of these examples of where hospitals like Kaiser, children's hospitals also are investing in local neighborhoods.
Excellent, George.
Yeah, and I think from that community benefit leverage that you just described is a tremendous opportunity. And actually in Baltimore, we're in the early stages, but it's definitely tangible with a partnership with Kaiser Permanente. Now, in Kaiser Permanente, the Mid-Atlantic division. Yes. But in our market, there is it's not a competitive situation. Kaiser Permanente doesn't operate hospitals in Baltimore, but they all do insure people, and they are concerned with population health. And so we're working with them on expanding the programs and services of Community Works that I described to you earlier, but also, more importantly, engaging the community in the neighborhood around the hospital, around the redevelopment of an old library that was abandoned nearly 20 years ago into a youth development center. And that actually brings up, I think, one of the most, I wouldn't call it a non-traditional voice, but one of the most important, if not the most important voice, which I think the healthcare world could learn a lot from community development, which is resident engagement. Yeah. You know, there isn't really an equivalent of a CHODO in the acute healthcare world. So there's one thing where they don't get mixed up and think you're talking about something else. You know, they just think you're from another planet. But now with the Affordable Care Act and the need for, you know, of course the upstream stuff we talked about earlier, but I think more critically in terms of a tool, you know, all the nonprofit hospitals now are conducting community health needs assessment, which require tangible resident engagement, which require an implementation plan, which requires resident engagement. So the healthcare world is learning a lot more about how to engage people, that just brings a lot of opportunity for mutually beneficial cross-sector collaboration.
Excellent, excellent. Yeah. So we're happy to take any questions from the audience, if there is one. It looks like there might be a couple. And it's very bright, so I'm going to start right here in the middle.
You're out there somewhere.
Yes, ma'am.
Okay, I have a two-part question, if that's okay. One is a little bit of a broader spectrum, and another is a little bit more narrow. So I previously worked in Chicago and helped put together the plan, Healthy Chicago 2.0, and it was a very progressive plan with a lot of public-private partnerships, local governments, the health departments, counties, businesses. So the first part of my question is, as an urban planner and a policymaker, what may be some low-hanging fruit to get conversations started about health? We are the Motor City. We have the 10th highest obesity rate in the state of Michigan, and we don't really have those conversations about health. And one of the things that I try to do in Chicago was implement a public health section in every community plan. But here it's much different, where we don't even start the conversation about health. And the second is a very quick, I think can be answered very quickly, is the problem of data. So planners and policymakers, we don't have the information to state the actual problem, to integrate it into our policies. And most of this data is held at the state and county level. So if you guys had any insight on how to better get data in your own experience to integrate that into some of our work.
Sure.
I can answer the second one first. So we have I struggle with the same issue. So we've done a lot of work to collect together in one place different measurement systems, different metrics approaches. We call it Measure Up. It's on our website. And two examples that pop to mind. One is called the Child Opportunity Index. It was put out by, I think it was Brandeis University and I think the Kirwan Institute at Ohio State, down to the census tract level, and they do an index of different measures of opportunity for children. And so it's very pertinent. You can also overlay race, ethnicity to get a better sense of where populations fall within the 100 largest cities in the country. The other one is actually Enterprise Community Partners, just published a few weeks ago, Opportunity 360. Mm-hmm. And again, down to the census tract level, a remarkable level of detail. And what I love about that, you just put in an address, and it spits out this complete report that is very readable, very understandable. I did one for my home address in San Francisco and one for my parents' address in rural Ohio. It's really effective to take two and compare them side by side, but down to a very narrow level. And I think those types of tools are going to be really useful as this type of work goes forward.
But you bring up a good point about the data sharing, and particularly in the cross-sector engagement and the silo busting that we talk about all the time, really trying to figure out how do we measure and how do we look at outcomes to ensure that also the interventions that we're doing are having the appropriate outcome that we're looking for. And I think that is a very transparent challenge that many of us face. At SAHF, we are a collaborative of nonprofit affordable housing providers, and we have been really moving towards data as a way to look at the work that we're doing from resident services at a property level to really show the impact from a funding perspective, but even from a health perspective, that if we can find synergies with the healthcare system in the services model that we provide on the housing level, that could really promote some cost savings and really improving the lives of who we're serving. It is much easier said than done, and we have some of our members in the room who could speak to that, but I'm very proud of being housers thinking about that, and the tenacity in making sure, understanding the complexities of collecting data and really showing your outcomes. So I think it's a great point. To your point about low-hanging fruit and health, I do think it depends on where you are. I argue, and my boss is in the audience, and she'll hear me say this all the time, that you can take any topic and I can promise I can spin it to a health issue, right? So if violence is your issue, that is a health issue. And so what is really happening at the community on the grassroots level? And so you help people to understand or get a sense of what's happening in their community, and then you say, oh, by the way, we've been talking about health this entire time. And the partnerships that we're looking at and the impact that we're really trying to make all get back to having that big H, health, not just the healthcare piece, really important. But I find that kind of meeting people where they are and what are really the issues on the ground, I promise you I can always take it to that level of making it a health kind of outcome issue. And I didn't know if anybody else had any thoughts.
Well, I just want to, I feel where you're, we have this kind of similar discussion in the healthcare world with my colleagues that are with Bon Secours and other healthcare organizations. And I think it's about identifying and explicitly describing the crosswalks that, we just had a health. I've gone to, brought my colleagues to community development and planning, neighborhood planning meetings, and they walk out and say, how come, you know, what about health? And I can tell them 6 areas where we talked about health.
Yes.
You know, and that's really, we've got to do a better job in the healthcare world to explicitly identify those crosswalks, because we speak such a different language so much of the time. You know, we're working out of the clinical realm. An example I would give you is high-level population health, but people don't necessarily look at mortality as being an economic development issue. But once you unpack that, you know, you can see where neighborhoods where, and that's a big issue where I work, where there's a roughly 20-year disparity between Southwest Baltimore and the more affluent neighborhoods, where when the average mortality is 68 years old, that means there's a whole lot of people dying at 52 and 48 and 61, and there's not any generational wealth being developed. So you kind of have to develop those crosswalks where you're talking about, it's actually the same issue.
Right.
The indicator's the same, but it has implications across the board.
Yeah, besides the siloization issue, and I don't know if this gets quite at your question, because I think part of it is getting access to stuff, and this data question is very, very big, and we could spend probably several hours on that alone. But I think the other problem we have right now was we're really sort of at a frontier of which data to collect. And what Doug's organization is doing is actually collecting data for the first time in a way that's accessible to a wider public about the relationship of some of these social determinants to health. And we just haven't been collecting that kind of information. You know, doctors, we were just talking about this before coming on, doctors don't assess for you know, traumatic early experiences, which ACEs, adverse childhood experiences. If we were to do so, then, you know, that might raise then the bar as to how, especially pediatricians, respond to the patient in front of them. But we don't collect that data, much less like housing data. We don't ask, are you like stably housed? You know, because if you aren't, you're at risk for many, many things. So part of the issue we need to do is really is to begin to traverse this data frontier and begin to ask, you know, what are the real questions we need to get to the outcomes we want. And my sense here in this audience is that we're really trying to drive towards a higher outcome for everybody, which means that maybe the data that we're tracking right now are not adequate to the job.
No, thank you for that. Well, I've been signaled we are out of time, but if we can give our panelists a round of applause and really appreciate their insights today. And thank you so much for your time, and hope you enjoyed the conversation.